Hello, and thanks for listening to the MiCare Champion Cast. In observance of National Caregivers Month, and knowing that 1 in 5 American adults are considered caregivers, this episode will explore the evolving landscape of caregiving and what resources are available to hospitals and health systems that want to integrate caregivers as members of the healthcare team. I have 2 guests joining me virtually. The first is Diane Mariani, a licensed clinical social worker and program manager for the Department of Social Work and Community Health at Rush University Medical Center out of Chicago. Diane manages the Rush Caring for Caregivers program, which supports family and friend caregivers of adults 60 years and older. We'll also learn more about her work leading an initiative funded by the John A. Hartford Foundation in an effort to share a caring for caregivers model with age-friendly health systems, area agencies on aging, and other key stakeholders nationwide. Diane, thanks for being here today.
Thanks, Lucy. I'm really excited to be here. This is a topic that is really important to me in my life, both personally and professionally. So thank you for having me today.
Our second guest is Josh Suire, a registered nurse and senior manager of quality and safety at the MHA Keystone Center. In his role, Josh is responsible for operationalizing clinical grant-funded initiatives that help hospitals and health systems implement evidence-based quality improvement and patient safety practices. Most recently, Josh has been working to bring national caregiver models and programming to Michigan, which you'll learn more about in today's conversation. Josh, great to have you. Thanks for being here today.
Thanks, Lucy. Yeah, it's great to be here. And I think the timing's great with it being National Caregiver Month. And also personally, I had an injury about 2 weeks ago, and I've actually had my own caregiver as I sit here and work. So I think the timing's perfect.
Yeah, absolutely. Well, we hope you're doing okay. It was a foot injury, right?
Right. Yeah. Fell down the stairs giving some kids Halloween candy. So
oh no. Oh.
Yeah, wasn't the best. But.
Well, you can speak to it from a personal and professional standpoint then, it sounds like. And I know you both have a lot of really valuable insight and knowledge on this topic. So we have a lot to cover today. But before jumping in, I would love if you could both just tell us a little bit more about your backgrounds and where you come from and what led you to your current position. So Diane, if you don't mind kicking us off.
Happy to. I'm a licensed clinical social worker, and I'm working at Rush University Medical Center in Chicago. And prior to my work in family caregiving in that area, I was an oncology social worker. So I worked in our cancer center for many years. And what I found even in that environment, which I'll just say I really loved doing that work, what I found, though, is oftentimes I worked or spent more time with the family care or the family members than I did with the patient. Certainly spent time with the patient, but it just seemed like the family members needed their own support, and it was oftentimes they were the ones coordinating care. So I just got that insight early on, and so I really appreciate that I then transferred into this wonderful area of supporting family caregivers. Really just all I'm doing is in that area. So just happy to start talking about this important topic.
Josh, can you give us some background on where you come from and how you got to your role at the Keystone Center?
Yeah, great. Thank you. So my name is Josh Suire, and I'm a registered nurse by background. Can't believe it's actually this year is 15 years as an RN.
Wow.
Quite a bit of experience at the bedside. About 10 years I was at the bedside, mostly in med-surg and ICU. And after that, I went to quality and safety, where I worked a lot with the early identification and treatment of severe sepsis and septic shock in the acute care environment. And I worked a lot with the Keystone Center during the HIN or HEN ages of quality improvement. And I always loved the work that they do, and I loved working with them to increase safety, decrease sentinel events, adverse events. So when I had the opportunity to join the Keystone Center, it was really interesting because we were in a time where we were kind of reframing a lot of the work that we were doing. And one of the topics is bringing caregiver programming to Michigan, which right now, is a challenge in Michigan. We do have a couple of health systems that have some pretty robust caregiver programs, but it is one of our goals to not only work with those health health systems to develop best practices to spread around the state, but also really go after even additional funding for us to be able to help our members bring this programming to their organizations. So yeah, it's been a very interesting nursing career so far, and I'm just really excited to be part of hopefully a large movement that really brings caregiver programming to the forefront of what we do.
Absolutely. Yeah. And I think today's conversation is going to lend a lot of insight and allow people to get more involved in that effort. And I think both of you having clinical and non-clinical experience is going to be invaluable to the conversation. So I mentioned at the start of the show that, and both of you have mentioned, it's National Caregiver Month. And research is showing that bringing caregivers into the conversation better serves patients in the long run and actually leads to better health outcomes. But also, we're finding that the mental health of caregivers is declining. So can each of you just start by giving us your perspectives on that and touch on some of the evolving needs of not only patients, but also caregivers? Diane, if you want to kick us off, or Josh, either one of you, I'd love to hear from you both.
Thanks, Lucy. Yes, so at Rush, we involve caregivers on a couple of very kind of important levels. One is in the work that we're doing around our Caring for Caregivers model, we have established a caregiver advisory council. So this is basically a group of caregivers that are in caregiving currently, have that experience, and we want to hear directly from them on any of the work that we're doing as we're developing our model, as we're creating even marketing materials, or as we're sharing and teaching other health systems around supporting caregivers. We're involving them.
Mm-hmm.
We meet with them on a regular basis, and they're really providing us with feedback on the ways they feel that healthcare systems can serve diverse populations, and how we can best identify, assist, and understand caregivers and what they do.
Mm-hmm.
And also including how it impacts their physical and mental health. So we're hearing directly from them. Certainly, there's a lot of information out there now and statistics around the impact about mental health. And in fact, I'll mention that in 40 to 70% of family caregivers that have been surveyed, and this is caregivers of older adults, let me be specific
Mm-hmm.
about that, there are clinically significant signs of depressive disorder. And then a quarter to a half of that group also meet the criteria for major depression, as well as experiencing 2 or more chronic diseases. So taking that into account, there's just a significant mental health impact that we really need to be considering and hearing directly from the voices of caregivers on how to really address that.
Right.
And the second thing that we're doing is we have an employee resource group that is for caregivers. So within our health system, which is very large, we have an employee resource group where anyone within our health system that's employed by Rush can join this group. And so we support each other, and we're hearing from the voices of caregivers in that space as well. And as we're doing that, we're incorporating that into the work that we're doing on that national level.
Absolutely. It sounds like you're practicing what you preach, which is fantastic. And would you say that the statistics that you mentioned are aligning with the feedback? Are you comfortable sharing some of the feedback or anecdotally that you've gotten through that advisory council?
So yes, so some of the feedback really is kind of their own personal experience of and voice on how it's been impacting their health. And in fact, I'll mention that one of the examples I can give on some of the feedback we got was they unanimously agreed that they want their primary care physician, so their main doc, whoever they see, we all have that, or most of us have that. They want them to be asking, are you providing care for somebody? Because they feel it does impact their health. So that should be incorporated into their health plan.
Mm-hmm.
Their doctor should know that and factor that in. And we've had some that have said, because I don't think I would have the exasperation, my heart issues, or whatever those specifics are, if I wasn't providing care. It's extra stress, if you will, or strain. And that's a difficult thing to even say, because it also, caregiving brings meaning, and many folks do that very willingly, and they wouldn't change it. But the reality is, I'm willing to do it, I'm doing it, I wouldn't change it, but it does have an impact. And we want our healthcare system and our providers to know that and recognize it and help support us in that.
Absolutely. Absolutely. Josh, in your work, what are your thoughts in terms of how it serves patients and also the toll that it might be taking on caregivers?
Yeah, we know that caregiving in the United States, it's on the rise. 20% of Americans report being a caregiver or having some sort of caregiver responsibilities, and that's increased in the last 5 to 10 years. In 2015, for example, we had 43.5 million caregivers in the United States, and that went up to 53 million between 2015 and 2020. So we're seeing pretty exponential increases in the amount of caregivers that are out there and people that require care. There's multiple reasons for that, including obviously the aging population. But when you really think about mental health, 3 out of 4 employees have some current caregiver or caregiving responsibility, which that's a pretty staggering number. And you can imagine that trying to balance obviously family life, work, and then family dynamics or caregiving, it does result in emotional strain, social isolation. And we also know that through research that isolating patients from the people who know them best places them at greater risk for medical errors, emotional harm, inconsistencies in care, and costly unnecessary care. So really, I think we're at this critical time where we're trying to find a balance between involving the caregiver in all activities in which they really need to be involved in to take appropriate care for the person that they're caring for, but also ensuring that they are not at high risk for burden, burnout, or any worsening mental health condition. So it's certainly a challenge. It's interesting because I think that there's a lot more research, and caregiving is it's really a national topic right now. There's so much funding and buzzwords out there about caregiving, which is wonderful because this isn't a new topic. But we saw during COVID that some quality and safety indicators went the wrong way when caregivers were not at the bedside, either helping their loved ones or when they weren't there to be present to understand what care is going to look like post-discharge.
Right. Yeah. And before we get any further into the discussion, you brought up buzzwords, and I think it's important to note that everyone very likely has a very different understanding of what the word caregiver means. So would you describe, each of you, the role of a family caregiver in the context of today's conversation? Josh, if you want to start us off.
Yeah, absolutely. It was interesting. So when we started really doing this work at the Keystone Center, the first thing that we had to identify is, how do we define a caregiver? A lot of caregivers do not identify themselves as caregivers. They might identify as, I'm a husband, or I'm a wife, or I'm a friend, or I'm a neighbor, or I'm a cousin, etc. I'm not a caregiver. So helping folks even understand what a caregiver is, and setting that tone, I think, is crucial. It was amazing the amount of conversations we had, because even some hospital staff call their staff caregivers, and we don't want to, create confusion on, is a paid, licensed social worker or registered nurse considered a caregiver? Absolutely. But in the context of which you're having that discussion, it is helpful to define caregiver in the way that you're trying to convey what that means. So through the work here at the Keystone Center, we typically say it's a relative, partner, friend who has a significant relationship with and provides services for another person. And they may be primary or secondary, or they may live separately from that person, but typically it is an unpaid role.
And Diane, would you add anything to that definition of family caregiver?
Oh, I totally agree with Josh. It's something that we kind of always think about. We certainly discuss with our caregiver advisory council as well. And there's a cultural component to that as well, because for some languages, there's not even a translation for that word caregiver or anything like that. So even considering that, cultural aspects won't even allow, for lack of a better word, it just doesn't connect with that idea. It's really, this is family, and it's a family role, and it's embedded in culture and and, what you do in your family. So it sometimes can be a foreign concept. So that's our challenge as providers and supporters of caregivers. So we also consider that and very rarely use those terms. Caregiver or care partners is out there as well. Carers is another one that's kind of used in the European areas and other areas abroad. So we kind of approach it as inquiring. So, are you responsible? Are you providing care for a family member or friend with a health condition or disability? Are you helping with medical care or household needs, shopping, or anything like that? So we kind of have that conversation and describe what we're asking about. And so in that way, that we'll get maybe a response that, yes, I do. I help with this or that. And then it starts that conversation. I will add that, again, considering what we've just talked about as far as identification, when we're engaging with caregivers and start really having that conversation, we also use some evidence-based tools to kind of get at what their needs are and really understand what their needs are. And some of those questions will then elicit kind of some self-identification. So there's a scale that we use called the burden scale for family caregivers. So as we ask these questions, one of them, I'll give an example, is I often feel physically exhausted. And of course, it's all based on the care that you're providing. So as caregivers are answering these questions, it starts to kind of connect with just whatever this is, this care that I'm providing is having an impact. So that sometimes helps them identify in being in that role, more effectively.
Right. Absolutely. And I think a theme of today's conversation that I just want to state out in the front is that the people that are in the non-clinical roles and clinical roles and unpaid and paid roles, this conversation isn't designed to, pit one against the other or insinuate that one has a harder job than the other. I think the point of this conversation is to show the importance of everybody and the importance of integrating those family caregivers into the more traditional caregiver team within the hospital or health system setting. So with that in mind, can you paint a picture, Diane, if you don't mind kicking us off, what a day in the life of a family caregiver might look like?
Well, if I could summarize that, as I'd be, that would be really something, because here's the thing, it's, there's certainly some common elements, I'll say, that we find across that role of caring. But really, the day in the life is so varied and so individual, and there's so many aspects involved. But it's a great point to bring up because it's important to note that. So
Right.
I think from our perspective, as we even develop the support that we provide, is realizing that. So it makes sense that some form of I'll just use the term cookie cutter approach may not be sufficient. Any support is support, which is always good, right? And so
Right.
you can piece things together and folks can choose from what they think will be beneficial. But we like to look at it and take a very individualized approach, because we have to find out what is that day like for that person. What is that day like? What is that week like? For some, it's very intense and involved. For others, it may at this time be just starting and it's light and everything. But based on the condition of that person they're caring for, there's going to be a trajectory of increase. And so just all these aspects, family dynamics may be in play for one caregiver situation, but not necessarily for other. One may be more of a difficult or challenging dynamic. One may be a very supportive dynamic. Somebody might live very nearby the person they're providing care for or live with. Somebody might live, an hour and a half away or even another state. So just one may be work, et cetera. You get the picture that it's just so individual. That caregiver may also have their own health issues. So incorporating that, what does that mean if they have their own concerns and things that they have to care for? So again, just that's that conversation that you have and that engagement. Tell me about your situation. And that's how you can then provide that support.
Absolutely. Taking into consideration all the elements, not only of the person they're caring for, but also their life and the needs that they might have. Josh, anything you would add in terms of common elements that you might see in the day of a caregiver?
Yeah, I really wanted to elaborate more on what Diane was talking about with family dynamics, because it's really interesting when we try to look at what does a typical day of a caregiver look like. Obviously, it's very different for everybody, but family dynamics are a very significant. They play a significant role in what that could look like. We try even not to use the term like loved one, because that may not be the dynamic that that caregiver in person is
Mm,
in. They may be family, but everybody's background is different, and it's important that we assess that and we try to use language that does not place a label on a family dynamic. I can give an example as well. We were talking about the difference between paid caregivers or unpaid caregivers. I was my mom's primary caregiver for about 6 years before she passed away,
mm,
and I was a registered nurse, and I worked at the local hospital that she would get care for very, very frequently. But I'll tell you that when I was at the bedside, and even though that was my employer, I didn't wanna be a nurse. I didn't feel like
mhm,
a nurse. I felt like a caregiver. I
mm.
felt like a son. And I think there's a lot of assumptions as well when you are a healthcare professional, you have that experience. People say, "Oh, thank goodness," "Oh, you probably already know this." But I would challenge that. For even an
Mm,
example, I think about this all the time. At one point, my mom had a foot injury and her foot was bleeding out pretty quick. And, if I was in the ICU, I'd raise the foot, I'd put pressure on it,
mm.
basic interventions. That all went out the window. I didn't even raise the foot because I wasn't a nurse at that point. So I
Right.
think it's really important to understand not only, like I said, the family dynamics, but also that healthcare is one of the top employers in the United States, and a lot of people are in healthcare, but also recognizing that even though
Mm,
somebody is in healthcare, they may be a caregiver first and a clinician second.
absolutely. And I'm sorry to hear about your mom, Josh. I appreciate you sharing that as an example of how different the role can be, even if you have the context of being in the clinical side versus if you are the family caregiver yourself. So, with that in mind, do you mind sharing some of the benefits of having a caregiver be a part of the healthcare team?
Yeah, absolutely. We learned a lot during COVID, and I don't have a lot of the stats pulled up, but we do know that when caregivers were not at the bedside, and I also, in full disclosure, there is other factors that probably affected these numbers, such as high incidences of isolation and things like that in the hospital. But we know that falls increased.
Mm,
We know
hmm.
pressure ulcers increased. 10 years of clinical quality improvement work here in Michigan. It was really, really staggering to see how 10 years of improvement could completely go backwards in a year and a half during the pandemic. But that was echoing the importance of also having caregivers at the bedside. And it was really interesting. We've talked with some of our
Hmm.
Michigan hospital members. And, I'm thinking back when I was a nurse, sometimes it can appear to be extra work when there's multiple caregivers. You have to re explain things or you have to go over things multiple times. And it was interesting that we were hearing feedback
Hmm.
that we want caregivers back. We would rather go over things multiple times, or they not having them at the bedside. It was really, really interesting seeing frontline staff almost saying we want them back. Now, I'm not saying that that's the case in every scenario,
Hmm.
but that was a key takeaway. And we know
Right.
that having family caregivers at the
Hmm.
bedside, it helps with overall cost savings at the hospital. It enhances the patient and family experience of care. It improves management of chronic and acute illnesses. And it does prevent hospital readmissions, which is part of the work that we're currently doing is how can we look at robust visitation policies during a public health crisis such as a pandemic and try to ensure that in the future caregivers are allowed at the bedside. Obviously, with things like PPE shortages and things like that, there are uncontrollables and there is no one size fits all. But really having those conversations and starting
Hmm.
programming around caregiving really is the next step that we're hoping to bring to Michigan and really have those caregivers be part of the hospital team.
Right. Would you say COVID has changed the landscape of how family caregivers are perceived by healthcare teams?
Yeah, I would say that. It's interesting the feedback that we've gotten from, some it's actually more devastating than interesting. Hearing stories of folks having to visit through a window or, not being able to visit at
Mm-hmm.
all. That
Right.
and seeing those negative health impacts and really how the two really are connected.
Right. Absolutely. Diane, any other benefits you would highlight in terms of having the caregivers be a part of the hospital care team?
Oh, absolutely. So we did learn so much from COVID. So, which was really good, and it certainly, I do think it did impact many healthcare providers' views of the importance of family caregivers. That being said, still more work to be done in that area
Mm-hmm.
because it can be seen sometimes as an additional consideration or extra time spent, and so that can be difficult. Or healthcare providers have limited time sometimes with to spend with patients, etc. So that can be challenging.
Mm-hmm.
But the benefit of really involving that caregiver, I mean, that caregiver has direct access to that person that they're providing care for, and those frequent
Mm-hmm.
interactions that they have allow them to really monitor health changes on a more regular basis than the healthcare providers are aware of. So they're seeing them
Mm-hmm.
maybe day to day, or at least week to week, or in some frequency. And so when you can really collaborate with that and include that voice of that caregiver, it's going to improve, first of all, that person's access to services, because usually the family
Mm-hmm.
member is helping with those coordinations, etc. And I think it reduces the unmet needs of the patient, so to speak. So I'll give a quick personal example as well, that I had recently had with my mom. I was also caring for her for a number of years, and the more recent, she was having some symptoms and concerns, and we went to see her primary care physician. And I was trying to, I mean, they had done some lab tests which were showing one thing. I get it, there it is. But
Mm-hmm.
I have a rich amount of information to tell you what baseline is and what's happening now. So that I felt
Right.
like that should just be considered. It's a robust piece of information that should be included with the lab tests and the this and the that. And I didn't feel that that was actually happening during that visit. And in
Mm.
very short order, mom wound up hospitalized due to those symptoms that I feel could have been avoided had the caregiver's input been considered and maybe addressed. So that's something that we also work with caregivers is, advocating. And if you get a provider that kind of doesn't really maybe see what you're trying to get across, then you can continue to advocate and take the next steps that you need to, et cetera. And we want to empower caregivers to know that they're part of the healthcare team, whether or not the healthcare team is at that point yet.
Right. Absolutely. And with that in mind, I actually leads very nicely into my next question, which is what advice would you give to a caregiver when it comes to advocating for themselves within those larger institutions?
So I'll just say, it can be very individualized, and so
Hmm.
we just support them with kind of where they're at and determine, you know, uh, how they're viewing healthcare. Many can still see it as okay, whatever the doctor says is, we're just going to, that's what they want us to do, etc. So we kind of suggest, it's okay to advocate for yourself and for your person you're caring for. Sometimes you have to
Hmm.
be persistent and be the one actually is doing more legwork, which of course that's difficult because they're already, the caregiver's burdened to a certain degree. But just kind of knowing that healthcare is, kind of stretched at this point. It just, the reality of
Hmm.
it is many, let's say, and I'm not disparaging healthcare. I work for healthcare, and, I know the professionals, we're doing the best we can, but there's a reality to what's happening. And then we kind of support, asking questions, what questions to ask, how to ask questions, or getting clarification, and just really being able to, take your space, own that space. I'm going to speak and share and inquire, because what I have to say is impacting the person that I am caring for.
Absolutely. When you say how to ask questions, can you elaborate on what that might look like or what advice you provide?
Well, sure, because some, again, some are just not feeling that they have that right to voice
Hmm.
or to speak out. So, if we're working with that caregiver, we'll kind of do some role play on that and just really coach them on, you know, knowing and that they have that inside information. They
Hmm.
know what they know, and they see little things, and whether somebody thinks it's nothing or not, it's really just being able to get that across. And also we kind of talk about, sometimes you find your champion. So if it's an inpatient setting, you might have the hospitalist come in, and maybe it's a quick and they're not hearing you, but there's that going to be that nurse, that gets it or hears you, or the medical assistant. So it's really just kind of making sure you're kind of telling what you know, or asking of everybody on the team. So that's part of what we
Hmm.
talk about as well.
Absolutely. Josh, anything you would add in terms of advice to give a caregiver to empower them to serve as an advocate?
Yeah, I think Diane covered it really well. The only thing I might add is if you don't understand, either an instruction or how to do a procedure, and you'll be the person ultimately taking care of that person once they get home, really, it's okay to ask for more education. It's okay to say, I don't quite understand. It's okay to write questions down,
Mm.
and when the provider is rounding, to have those questions ready. And also advocating to be part of the discharge process. We do have the Michigan Caregiver Act here in Michigan. So it is a regulation that identified caregivers are contacted prior to discharge. But I think there's a difference between being contacted and being actively engaged in the discharge process. So letting folks know, even on admission, looking already at discharge, I need to be involved in this process, or even ask to be included in doctor
Mm.
rounds, which this is a challenging topic because, rounding physicians, it may occur at different times of the day. There might be some lateness. It's really hard to narrow down an exact time, but at least trying to advocate and letting the care team know that you want to be included in pretty much all aspects of patient care. And sometimes caregivers are advocating for a break, honestly, during a hospitalization. So, again, this is where the typical day in a caregiver might be different. Maybe they haven't had a day off in several months, and they take the day and they lay in bed and watch a movie and actually get to take time for themselves. So I would say advocate for what is important to
Mm.
you as a caregiver. If it's time for you, excellent. If it's time to really start learning more about how to do, whether it's procedures or anything like that, great. Really, no one size fits all.
Right. Absolutely. Diane, anything you would add there just on the side of having caregivers feel comfortable asking for help themselves? We didn't touch on that as much.
No, that was really good, Josh. It kind of reminded me of, and you mentioned it earlier too, about like, when you were caring for your mom, and that you had that situation, and here you are, a nurse by training, but at moments you're a caregiver and a son. I had that experience with my dad, who I also cared for, um,
Mm.
and the emotion that comes in when you're providing care and concerned about their well-being. And I know that I at one point he needed to have IV medication administered on a daily basis, of course, in the home. And so I was provided training. I was shown, let me say, I was demonstrated how to do it by the home health nurse. And I was watching intently, and I was paying it. I was very like, I'm in it, I'm watching, I'm listening. Okay. And she's like, and it seemed very simple because she did it so easily and smoothly. And then the next day when I was charged with doing it myself, I could not remember If I do this first or this
Mm.
next, do I do this and that? And there was such a panic and emotional stress over not only I might not do this properly, I might actually cause harm. First of all, I'm not helping because he needs this medication and I'm not able to do it. But am I causing harm if I do attempt to do it and do it wrong? And now I've caused some additional issue. It was just really frightening. And so, that was a learning experience for me that I didn't know what I didn't know, so to speak. And even though I thought I was getting it, so really we also talked to caregivers about, have them use like a teach back approach. Like, so I probably would have done better had she showed me, and then I kind of did it myself and went through it hands on. That might have helped. I did obviously then reach out by phone and contacted them, and they walked me through it over the phone. And then when they came back for another visit, I had them show me again. So again, those are the things we kind of tell folks, that you just have to speak up and advocate for yourself. As Josh mentioned, if it's a part of the discharge, they're supposed to really ask a caregiver if you're ready, willing, and able. What if I'm not ready to take on now these new things that have to occur in the home? I was doing this maybe so far, but now all of a sudden there's going to be oxygen and IV medication and wound care. So then really being a part of that and determining if that's something they're able to do.
Right. Absolutely. Well, Josh, I know we're early in the process of piloting the implementation of a caregiver navigation program. So just to switch gears a little bit, can you tell us more about that?
Yeah, absolutely. I think I'll start with just giving a brief history of the work here at the Keystone Center. During the pandemic, we were approached by one of our partner funders, the Michigan Health Endowment Fund, to do some research on what would it take to bring caregiver navigation programming here to Michigan. Now, that being said, there have been hospitals out there that historically have done some great work, notably Henry Ford Health and their care program. So we had the opportunity to, during COVID, to just kind of take the time to analyze some hospitals and health systems that do have more robust caregiver programs and try to turn that into an actionable toolkit and a gap analysis. So if I'm an organization that essentially is starting nowhere with the caregiver program, how do I operationalize and set this program up? So we spent about a year and a half with Wayne State University's Institute of Gerontology and Henry Ford Health and a couple of other great partners to develop this toolkit. And as part of phase 2 of the funding, we have recruited 2 hospital partners to implement the toolkit and try to develop a new caregiver service line in their setting. So we currently have Trinity Health Oakland and University of Michigan's Caswell Diabetes Institute, which I'm very excited about because they're very different service lines. We have one inpatient med-surg unit, which is supported by virtual nursing, and we have one outpatient specialty diabetes clinic. So it's going to be very interesting as we get deeper into this work to see how not only the gap analysis and the toolkit, its efficacy in both of those sites, but also is the toolkit more geared towards inpatient or outpatient? Because at this point, it's kind of a test. Working with Rush and Henry Ford to design workflows, we do workflow analysis. That's one of the key difficulties that we're finding as we start to build programming is once we get the program up and running, from referral to a caregiver program to discharge, what does that whole workflow look like? And it's interesting because there's so many models out there. Some are ran by social workers, some are ran by nurses, some are ran by community health workers. So we're trialing a couple of different interventions at each site. Something that's interesting is we constantly have to remind ourselves this is a caregiver program. We always want to go back to patient education. Obviously, the patient is a huge partner in the caregiver program, but it isn't a patient navigator. It's a caregiver navigator. We're focused on identifying caregivers, what are their unique needs, trying to decrease their burden or burnout scores, and really trying to improve the quality of life for caregivers. So it's really exciting. We do have some really exciting preliminary information. And, one of the biggest challenges really is funding right now. There are some new codes that you can charge for certain caregiver education that came out in 2024. I know Diane, I believe Rush University is currently kind of piloting some of those codes, but they're also pretty stringent on who can complete those interventions, how to bill, which goes back to what type of clinician is running your program, a nurse, a social worker, and there's certain licenses that you have to bill for it. So we're learning a lot. I mean, we do hope that as part of phase 3 that we could get a larger cohort and continue to spread this throughout the state.
Absolutely. Well, with that in mind, what resources are available for hospitals who might be interested in working with us?
Well, we have the Michigan Caregiver Navigation Toolkit, which is available on our website, MHA.org. You can click on the Keystone Center, and it's under older adults. We also have built a new caregiver module, which is in our learning management system. And that is a 7-part course on implementing the 7 key strategies of a caregiver navigation program. And you can also take a gap analysis online. Once that gap analysis is complete, it'll go to our center and we can process an individualized report for members, which would give them tangible next steps if they want to start beginning their journey to a caregiver program. And we also are currently building a new module series. Diane and myself are working on a 3-part series on identifying and understanding the roles of caregivers, as well as using standardized assessments to provide timely interventions.
Oh, can you tell us a little bit more about that? Either you or Diane?
Yeah, I can elaborate on that. Actually, as of today, it is live. So in recognition of National Caregiver Month, we really wanted to roll out a fairly robust, not only this podcast to talk about the importance of family caregivers and their role in the healthcare system, but to also provide free educational materials, not only for caregivers, but for hospital administration or staff that are looking at bringing those to their organization.
Perfect. Diane, anything you'd add?
No, I'm just excited to be a part of it and just spreading, we have like I've mentioned, we have a model, our own model, Caring for Caregivers model at Rush that we're also sharing across the country. But, my overarching goal is not necessarily, I would love for healthcare systems to adopt the model that we have developed. But I also know there's just, everything's a point in time. So some systems may not be quite ready for a robust model like we have. They may just be able to identify or, certainly utilize what Josh and team have put together with the Caregiver Navigation Toolkit. So there's just people are kind of systems are at where they're at. And our overarching goal is we just want systems to now just start. Let's start identifying caregivers. Let's notice that they're there. Let's identify. Let's start understanding them, supporting them, and be on that trajectory of starting to include that, incorporate it into your health system. So that's kind of really what's at the heart of the work that I do. And if it's okay with you, Lucy, I'll just kind of share a little bit about our Caring for Caregivers model that, we, and Josh mentioned funding, which is always critical, funding. And, goodness gracious, if we could just have, easy access to some funding, we don't even need a lot to get things going. So what happened for us, we, of course, there's years of advocacy that always go into something before it actually gets off the ground. But after years of advocacy, we knew there were needs for caregivers that needed to be addressed. And we received startup funding from the RRF Foundation for Aging. And we are always thankful for that because we wouldn't be where we are at currently without them. And so we had that funding to then develop and create this model. And it is a model that has kind of evolved over the years of implementing. We gathered a lot of learnings. We pilot tested the model in other healthcare systems to really understand Is this something that could be implemented across the country, widespread? Can we really scale and spread this model? So what we found was not just was it important to keep the model as we developed it, meaning very individualized. We are individualizing supporting caregivers. So we are assessing them. We're having those conversations. We're assessing for those needs, and then we're addressing those needs for that particular caregiver. I think that's the key element to do. And we do it in a very holistic way. We're addressing many areas with one-on-one support, resources, etc. But the other key thing we learned was that the model needed to be adaptable and sustainable, of course, because funding only lasts so much, so it has to sustain itself, and it has to be something that can be easily adapted in almost any setting. So we made sure it was adaptable. We don't have a prescribed model that you have to follow this, or you're not doing it. We work with health systems individually to kind of discuss, what are your resources? What are your needs? What is the community that you're serving? Are you rural? Are you urban? Are you frontier? All those factors matter. And then we kind of chat with them about how they can begin and initiate this model of support for caregivers. So it's a really exciting time. And as Josh also mentioned earlier, we're thankful that caregiving is now finally getting some national attention. It's really, after years, I have to give credit to all of those folks that have done years of advocacy before my time, even getting involved in this work. And we're at where we're at, and it's an exciting time. And I'm sure Josh would agree, personally as a caregiver, and then professionally, that this is an ideal point in time for us, that we can really continue to do this work, get the word out to others that need to hear about it, and even have caregivers know you are seen and heard. We understand you. We want it. We're here to support you, and tell us how we could do that better.
Absolutely. Yeah. Well, what I hear you saying, both of you, is that we kind of have to approach how we take care of caregivers in the same way they have to approach their day-to-day, which is being very flexible and adaptable, and addressing their needs person to person and on a very individualized basis, as you said, Diane. I didn't get a chance, Diane, to ask you if there were any other resources available either at Rush or with our partnership with Keystone that Josh didn't uplift that you would when it comes to integrating caregivers onto the healthcare team.
Sure. So I'll say, like with our model, right now we're sharing it freely. So any healthcare system can connect with us to, just even start that conversation. And, we're just hoping to support them and like what's their starting point. We offer full training on our model. We have educational materials that we provide that basically is the implementation of the model step by step. So those are hands-on materials. We offer technical assistance as well with adapting and implementing the model and customizing it for their specific populations and, resources. And we're also very well connected with, again, working with Josh and his team and others across the country on various models, even in the dementia care world. The guide model is out. Many health systems are approaching that. That's a comprehensive approach to caring for someone with dementia or Alzheimer's. So, we're staying connected so that then we can be also a resource. As we're talking with systems, I may be connecting them to Josh and his team because it's a more appropriate fit for them to be working with him and his work. So I think that's part of something else to be considered, that we need to stay in partnership with each other and collaborate. It's not a one size fits all. And all of the goal for all of us is to just have support for caregivers widespread.
Absolutely. Josh, can you close us out by just sharing any other efforts underway in this space at Keystone?
Yeah, absolutely. And also, I just wanted to reiterate what Diane was saying about both of our programs, the C4C or Caring for Caregivers model at Rush, as well as our navigation toolkit here at the Keystone Center. They're both very different, but they both want to accomplish the same goal. And that's exactly what Diane said, providing resources for caregivers to increase their quality of life. But to quickly differentiate the two models, our model here at the Keystone Center is more of an operational how do I get a program up and running? So we're talking about
Mm.
things like hiring FTEs or allocating resources or creating new departments, whereas the Caring for Caregiver model is much more clinically relevant. So once we've identified a caregiver, what assessment do we use? And once we
Mm.
have a result of assessment, what intervention should we be doing? So I think they complement each other beautifully. It's almost like it's a step in a way. Like you could start with the Keystone model and then implement the Rush University model once the program's up and running. But there are lots of great things that are coming out of the Keystone Center. I mentioned the new module series, which is available for free for anybody across the United States. It's an open course. And I got to give a special thanks to our funder, the Michigan Health Endowment Fund, who allowed that to happen. And we'll also be having 2 more modules coming out next year because this will be a 3-part series. Also, we will be having the Michigan Quality and Safety Symposium in 2025. And Diane will be joining me next year in the Lansing area, and we'll be doing a couple of breakout sessions specifically around the importance of caregiving and, helping folks that are interested either get connected with Diane or myself, and we can start doing the gap analysis and really start working together to enhance programming.
That's fantastic. I will see you both there. I plan on attending.
Excellent.
Great.
Perfect. Well, wonderful. I just want to thank you both again for being here today. There's a lot to be taken away from this conversation, and I'm going to make sure to hyperlink to all the resources that both Josh and Diane mentioned throughout. And I just can't thank you both enough for being here. So any last thoughts from either of you before I let you go?
I'll just say thank you so much for inviting me into this conversation. It's been my pleasure and honor to be a part of it.
Thank you so much, Diane.
Yeah, thanks so much, Lucy. I appreciate you not only reaching out to make this a priority for our members, but also for our podcast listeners. So if anybody has any questions, please feel free to reach out to myself at jsuire@mha.org.
Perfect. And we'll be sure to include that in the description of the episode as well. But as always, we'll link to all the resources, and just want to thank all our listeners for tuning in and encourage you subscribe to the MiCare Champion Cast across streaming platforms and head to MHA.org to learn more. Thanks so much.